Hi, everyone. Welcome to the Women's Health Seminar Series. We're very happy and excited to have Dr. Nichole Fairbrother with us today. And our talk is titled Postpartum Harm Thoughts, OCD, and Infant Safety. If you hear anything interesting today, please feel free to tweet it and tag us at researchonWH on Twitter with the hashtag WHSS. And before we begin, I'd like to acknowledge that we live, work, play, and participate in community on unceded, ceded, and traditional territories of the 203 First Nations, along with 38 Métis chartered communities, each of which possess their own unique traditions and history here on this land that we now refer to as British Columbia. We acknowledge the importance of the Truth and Reconciliation Commission of Canada's call to action, the United Nations Declaration on the Rights of Indigenous Peoples, and the BC Declaration on the Rights of Indigenous Peoples Act. In all of our work, we are committed to ensuring Indigenous women's rights to health and safety, and the equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. The Women's Health Research Cluster is based in Vancouver, which is part of the unceded homelands of the Coast Salish peoples and the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. And as we get started, I encourage you to use the chat feature to let us know where you are joining from. So if you're not familiar with the Women's Health Research Cluster, we have over 420 members that are scientists, students, and community members that live and work in 18 countries around the world. We have a number of different events for diverse audiences, give out several awards to student members, and collaborate with community partners. If you're interested in becoming a member, go to our website and click Become a Member. Membership is free and gives you access to members-only services such as awards and research facilitation. And with that, I will read Nichole's bio and welcome her onto the stage. So Dr. Nichole Fairbrother is a Michael Smith Health Professional-Investigator, registered psychologist, and clinical associate professor with the Department of Family Practice at the University of British Columbia. She is the head of the UBC Perinatal Anxiety Disorder Research Lab, one of the only perinatal anxiety research labs in Canada. Dr. Fairbrother's research is in the area of perinatal anxiety disorders and epidemiology, with a focus on new mothers' thoughts of infant-related harm and perinatal obsessive-compulsive disorder. She is currently in the planning stages for a study of the mental health correlates of gender differences in the distribution of unpaid domestic labor and a randomized controlled trial of online CBT for postpartum OCD. And as many of you know, we always ask for a fun fact. And Nichole's fun fact is that she speaks French and does aerial hoop for fun, which hopefully we get some time at the end to talk about that as well. So Nichole, welcome, and you can share your screen.
Thank you very much. Can you please stop screen sharing?
Yes. There we go.
Okay, hang on. Yeah, hi everyone. Thank you so much for the lovely introduction. I am joining you today from the unceded territories of the Lekwungen and Songhees Nations, sometimes known as Victoria. And I'm hoping that I can give this whole talk and not be interrupted by any cats from working from home. So yeah, so I'm going to talk about postpartum thoughts of infant-related harm and how they relate to mental health and infant safety, and in particular to obsessive-compulsive disorder. And so I'm hoping that you'll learn some things about how common these kinds of thoughts are, how common perinatal anxiety related issues are, how these thoughts are related to infant harm, infant safety, and their relationship with mental health and obsessive compulsive disorder. And I'll be talking about both the existing literature unrelated to my own work, as well as presenting to you our most recent findings on this topic. And so as a kind of backdrop piece of information, just to let you know that there are a broad range of anxiety-related difficulties that can affect people during pregnancy and postpartum. And they include the core anxiety disorders, which you see listed here, trauma-related conditions, obsessive-compulsive disorder, which was until the publication of the DSM-5, if you're familiar with the DSM system of classifying mental health conditions, was previously an anxiety disorder and has now been moved into its own section, as well as health anxiety disorder. And when we talk about anxiety during reproduction, we sometimes also talk about constructs that are not specifically disorders, like pregnancy-related anxiety, symptoms of generalized anxiety, or fear of childbirth. And these are all anxiety-related topics that may or may not fit into one of the anxiety disorder categories. And I give you this backdrop so that when we talk about obsessive-compulsive disorder, or OCD, you have a sense of how that is situated among the various mental health conditions. So we know that anxiety disorders have a significant impact on functioning and are associated with high levels of healthcare service utilization, healthcare costs, and a diminished capacity for work. Some of the anxiety conditions, obsessive-compulsive disorder definitely being one, can sometimes be incredibly time-consuming for people who experience them and result in a lot of avoidance behavior or inability to get other things done. So in any given year, the anxiety-related disorders are twice as common as mood disorders including things like depression and bipolar disorder. We also know that anxiety-related conditions are 1.6 times more common in women compared with men, with potential negative effects for the fetus developing infant with very good psychosocial interventions. We also know that the anxiety disorders are the most prevalent of all psychiatric conditions, with a lifetime prevalence of close to 30%, a one-year prevalence close to 20%. And you can see, if we look at anxiety disorders in perinatal populations, most of this research has been done on women. And just to give you a little bit of information about that, in my research lab, we now work very hard at using gender inclusive and gender additive language, but it remains true that most of this research, when looking at perinatal populations, has been conducted on women as birthing people. And so you'll notice that sometimes I'm using gender inclusive language and sometimes I'm referring to women, depending on what's most accurate. So you can see that in the perinatal period, and again, we're talking mostly women here, that the anxiety and related conditions have a prevalence of close to 21%. And I give this background because I think it gives some context and helps you to understand why this feels like such an important area. So I'll start with a little bit of information about obsessive-compulsive disorder. And I'm sure most of you have seen a little bit of information, I don't know, in the media of people washing their hands excessively, etc. And I know that in some ways that's probably the kind of OCD symptom that's easiest to portray in the media, that has the easiest visual to give. But obsessive-compulsive disorder is characterized by two core symptoms. The first symptom is recurrent, unwanted, intrusive, and often distressing thoughts, images, or impulses, which the person then responds to with repetitive mental or behavioral acts intended to decrease the distress associated with the obsession. So as an example, a person could have the unwanted intrusive thought, what if my mom dies in a car accident today? And then the person responds to that by repeating to themselves up to 10 times, say, my mother is safe, my mother is safe, my mother is safe. And that repeating that phrase to oneself, even inside one's own mind, would be the same as the hand washing. The hand washing is going to be done in response to a thought about contamination. And we know that the adult lifetime prevalence of OCD is about 2 to 2.5%, with it being close to the one-year prevalence being close to 2% in women. And as you'll see in this talk, that changes a lot for perinatal people. So we know that pregnancy and childbirth are associated with an increased risk of OCD onset and exacerbation. And my most recent study that I'll be sharing with you today really elucidates just how big of an increase there is. And we know that postpartum OCD, when someone develops OCD postpartum, it's typically characterized by really rapid onset, as well as aggressive obsessions, often related to the infant. So thoughts, images, or impulses of hurting one's baby on purpose or of harm coming to one's infant, even though those thoughts are unwanted. And until our study came out, it looked like the prevalence of OCD was about 2.3% in pregnancy and 1.7% postpartum. And we know that OCD outside of the perinatal period is associated with impaired social functioning, marital and family difficulties, healthcare costs that increase, difficulty with work, money, life, etc. Perinatal OCD, we know, can interfere with parenting, social relationships, just day-to-day living. And I think a really important piece here is I'd like you all to think about this. I don't know if anyone on this Zoom call has kids, but let me ask you this. If you were having unwanted intrusive thoughts about stabbing your baby or touching your baby in a sexual way, how likely would you be to rush to your doctor and tell them? And I think if you just think about what that might feel like to tell someone else about those thoughts, it can help you to understand that in general, people with OCD experience obsessions that feel really morally repugnant to them, that they find morally disgusting. They're often afraid, what if I act on the content of my thoughts? And then if you move that into a perinatal population of people having unwanted intrusive thoughts of hurting their baby on purpose, they are really, really afraid to tell anyone. And so in some ways, I think this issue has gone under the radar, that we've grossly underestimated how common this is, how impactful it is, because typically new mothers don't want to tell anyone because they're afraid, and justifiably so, that someone may take their child away from them. And so we have anecdotal reports of therapy clients and research participants who had disclosed these thoughts to someone, and they were then monitored for child abuse, or in some rare cases had had their child removed from their care. So now we're going to switch to unwanted intrusive thoughts and how they relate to the perinatal period, with this backdrop of understanding about perinatal anxiety and more specifically OCD. But before I do that, I just want to tell a little story about how I got into this area, because I think it's really important for people to know, and particularly for junior scientists to know, that so much of the research any of us does is really driven by experience and passion. And so I had grown up as a PhD student in Jack Rackman's research lab. He was an OCD and anxiety disorders researcher. So I was developing as a junior scientist in an anxiety disorders lab. And I became pregnant with my first child. I fell in love with reproduction at that time. And when my first child was born, I had some really interesting and, I guess, unwanted intrusive thoughts. So I remember having the thought, oh, I could just throw my son. We lived on the 7th floor in an apartment building on 10th Avenue near UBC. And I remember having the thought, oh, back when that was cheap enough, you could do that. And I remember having this thought, oh, I could just throw my baby out the window and go make breakfast. And then I also had this thought, oh, look at those tiny, cute little hands. You could just like cut those little fingers off with the garden clippers. They're so little. And my very next thought after that experience was, this is not how most people respond to those thoughts. My first thought was, wow, that is so cool. It's like I'm having an obsession. I've never really had a thought like that before. That's really neat. And I then thought to myself, wow, what would it be like if I'd had this thought at 4 o'clock in the morning? I'm alone in the dark, super sleep deprived. I have a little baby in my arms crying, and I know nothing about OCD. What would that feel like? Would I be frightened? And that was the beginning of my journey of studying this. When I started looking into this topic, people were like, yeah, I don't really think that's a thing. This isn't really, I don't know, this isn't really a big deal. It's not very common. And I think, you know, a decade or two later, it's clear that this is a much bigger deal than what it seemed in the beginning. So here's a question to you. And if you feel comfortable, you can put up your hand. I'll definitely put my hand up. Have you ever experienced an unwanted intrusive thought about doing something that you consider morally offensive, aggressive, sexual, rude? So I'm putting my hand up, and I'll give folks a second if they feel like it. Thank you. That's lovely for those of you who feel comfortable doing that. I ask this question because I think when you reflect upon your own experience, it makes it easier to understand what this feels like for a perinatal population. So what we know is that 80 to 90% of the general population will experience occasional unwanted intrusive thoughts that are morally repugnant to them. So this is kind of an everybody issue, and it's really a minority of people who never feel like they've had this experience. We know that unwanted intrusive thoughts are more frequent during times of stress. The content of our unwanted intrusive thoughts is related to our ongoing concerns and often morally repugnant. So if you think about new mothers, are they stressed? Absolutely. What's their current primary concern? It's their baby. So it's not surprising that there's an uptick in unwanted intrusive thoughts with content related to the infant in that perinatal period. The other thing that's really interesting is that you can't tell the difference between unwanted intrusive thoughts reported by members of the general population and the obsessions that are reported in the context of OCD, that the content does not distinguish between OCD and not OCD. And so, for example, if you listen to my thought about cutting my son's fingers, he has all 10 fingers still at age 22, that thought sounds very much like an obsession in the context of OCD. What we do know is that clinical obsessions tend to be longer, more frequent, and more distressing. So the fact that you can't tell the difference between OCD and non-OCD on the basis of the content of our thoughts led to a hypothesis that for which there is a lot of empirical support now. The unwanted intrusive thoughts will develop into obsessions and OCD if the person who's experiencing them makes a really negative interpretation that the thoughts mean something important about themselves or their future. So if the person experiencing them says the fact that I'm having these thoughts means, or the content of my thoughts means that I'm crazy, dangerous, or evil, they are more likely to go on to develop OCD. So it's really how we interpret those thoughts and what we make of them. And so in terms of postpartum unwanted intrusive thoughts of infant-related harm, they can come in the form of accidental harm thoughts and intentional harm thoughts. So what if my baby accidentally falls off the bed if I lay her down on the bed? What if she just rolls off the bed and gets hurt? Or what if I trip while carrying my baby down the stairs? But they can also be thoughts of intentional harm, like, what if I could just walk over there and step on my baby who's lying on the carpet? Or some of our research participants from Vancouver said, what if I push the stroller off the seawall? We know that these kinds of thoughts are upsetting to the people who experience them. They raise concerns about the potential for child harm, and they're possibly most similar to the kinds of thoughts we see in OCD. We also know that they're more among birthing parents compared to non-birthing parents. And to be frank, the amount of data that we have on the non-birthing parent is very limited, and we are in the process of preparing the funding application to extend our research to non-birthing parents. We know that among birthing parents, postpartum harm thoughts are more common, longer lasting, more distressing. But the non-birthing parent may have a harder time talking about them. And what we understand from that is that typically birthing parents are often breastfeeding and spending a lot more time with their infants, so it's not surprising that they may experience more of these thoughts. So before our most recent study data from our pilot study told us that everybody reports unwanted intrusive thoughts of accidental harm coming to their baby. There is a huge amount of safety related concerns around newborn infants. And I think that it would be really hard not to have intrusive thoughts about accidental harm coming to your baby. What's more remarkable is that fully 1/2 of our sample reported unwanted intrusive thoughts of hurting their baby on purpose. Compared to the thoughts of accidental harm, thoughts of intentional harm are less frequent, less time consuming, but not surprisingly more upsetting. So here's what we know about OCD and the risk of violence. Obsessions, no matter how awful the content, are not associated with an increased risk of violence. But at the time, until our most recent publication, this was something that we had accepted clinically, that was really well established clinically, that people with OCD are very afraid of acting on their thoughts. They engage in all sorts of avoidance and compulsive behaviors to control their thoughts and ensure that they don't act on them, and that there's no evidence that OCD is associated with an increased risk of violence. That said, there had not been a scientific test of that proposition, and so that is something that we undertook in the research I'll present to you in a minute. So, and then from our pilot study again, we looked at the relationship between having unwanted intrusive thoughts of hurting your baby on purpose and the likelihood that you would behave in a physically aggressive manner towards your infant. And we found no difference between the groups, that the people who experienced and reported unwanted intrusive thoughts of hurting their baby on purpose were no more likely to behave aggressively toward their infant than those who did not report those thoughts. But this was a small sample size of 100 people. The confidence intervals were really large. And so we then sought funding from the Canadian Institutes of Health Research to extend this research and replicate this finding in a larger sample. So just to shift over to this idea of aggression, I'm going to ask everyone to reflect on a time when you have behaved in a physically aggressive manner. If you are an unusually mature person, you may have to go back to childhood. Most of us probably don't. And when you behaved aggressively, even verbally aggressively, did it happen in the following way? You know, you get upset, you're really angry, you're really kind of agitated, and then you just kind of get so angry that you kind of lose it. And you say something you wish you hadn't said, or you do something you wish you hadn't done? Or were you kind of calm, but having unwanted, intrusive thoughts of behaving aggressively? And you just kept having these thoughts and images over and over until you finally just couldn't take it and you acted out on those thoughts. If you feel like putting it in the chat, you could put number 1 for the first one and number 2 for the second one, just so we can kind of see. My guess is most people will say number 1. Most of the time when we behave in a violent manner, our negative emotions exceed our capacity for self-control. Our impulse control becomes insufficient for the emotions we're experiencing, and we act in a way that we're unable to manage. I don't know, in my own experience, have never had just kind of flash images all day until I act on them. And I say that because I think it's, again, really important to help you understand, how is it possible that a new parent could have unwanted intrusive thoughts about hurting their baby and not actually be a danger to their infant? Okay, so here's where this takes us in terms of, what do we need to do about this? So we have to make sure that we get this right. So if we don't respond correctly to infant-related harming obsessions in particular, there could be serious consequences. But there can be serious consequences in both directions. So if in fact unwanted intrusive thoughts of hurting your baby on purpose represent a threat to infant safety, and they may very well do in some circumstances in the context of psychosis, severe suicidality, etc., then you have to act to protect the infant. That's your primary directive. But if they, in fact, in some circumstances, represent a normal postpartum phenomenon that may put a person at increased risk for OCD, but are not associated with an increased risk of violence, you really want to provide normalizing information. And if you don't, if you respond to that person as if they're at risk of harming their child, you may increase the likelihood that they develop OCD. So it really matters that we figure this out and get our response to this correct. Okay, so I'm going to switch over to our own most recent research. So I work with just this amazing group of people. Patty Jansen was my postdoc supervisor. Sheila Woody and Dana Thorderson are both anxiety disorder scientists who I worked with during my graduate work. David Wolf is a child abuse expert. Ariane Albert was the statistician for the Women's Health Research Institute and a lovely person. And Fanny is a graduate student working with me, and Fiona is a perinatal OCD expert from the UK. So I just had this beautiful team of people. We had great funding from the Canadian Institutes of Health Research, and we feel really pleased with how this has all worked out. So our core research questions for this, we have now multiple manuscripts in progress for this, but the really core ones were: how common is perinatal OCD? Are postpartum unwanted intrusive thoughts of intentional infant-related harm associated with an increased risk of aggression toward the infant? And is perinatal OCD associated with an increased risk of aggression toward the infant? So we included English-speaking pregnant people who were 19 years and older and living in the province of British Columbia during the study recruitment timeframe. We sought as representative a sample of birthing people in BC as we were able to manage. The primary method via which we attempted to secure a representative sample is that we engaged in proportional recruitment. So what that means is that we recruited via hospitals where I think there were 10,000 or more births a year. Maybe I'm getting that wrong. Maybe it was 5,000. And we recruited via all of those hospitals in British Columbia, but we recruited proportionally. So if hospital A resulted in 7% of births in BC, 7% of our sample was recruited from that birthing location. And we augmented that recruitment with some community advertising and some targeted rural recruitment because rural participants are harder to access. At the end of all of this, we then engaged in a little bit of data weighting around parity and age to bring the sample even closer to a representative one. And humorously, now that we're post-COVID, it seems crazy that we did this, but most of the recruitment was done direct approach, where we would walk up to people waiting for their medical appointments in hospitals, prenatal appointments, and we would ask to share information about the study with them. So the most important thing about this slide is that the photograph is a picture of my stepdaughter, who's now 4.5. Isn't she cute? And our data collection happened you can see how long research takes, from 2014 to 2017. We ended up with a sample of 763 pregnant and postpartum people. I think of note, not everyone provided data at every time point. So the prenatal assessment involved questionnaires and an interview. All three assessments involve questionnaires and interviews. The interview for the first prenatal assessment was a diagnostic interview for OCD only. The first postpartum interview, we added in questions about harm thoughts, which we didn't have in the prenatal interview. And then in the final interview, we kept the harm thoughts interview piece, but we also added a questionnaire about parental aggression. So we assessed child abuse, so to speak, in the final assessment for the study. And you can see that, in the first assessment, we had 695 people provide questionnaire data, but only 271 providing interview data, and so on and so forth. So we ended up with some variability in the questionnaire interview data that we obtained. So I think what's worth noting here is that we assess child abuse. Assessing child abuse is actually really complicated. So if you ask people, hey, have you harmed your baby? But you just kind of ask them that and they just tell you, and you don't put any protections or safety in place, people are not going to answer that question honestly, if you can report them to the Ministry for Child and Family Development. On the other hand, if you ask them this question and you can't report them, how does that feel ethically to collect this data and not be able to do anything to protect these infants? So we argued that it was better to have the data and not be able to report these individual people because the learning really mattered. And if we were going to be able to report them, there was no point in collecting the data. Some of our ethics boards had concerns about this strategy. So we actually reached out to the Ministry of Child and Family Development, shared our research methodology with them, and asked for a letter of support, which they were happy to provide. So they agreed that this was a reasonable way to go. And in order to collect this data anonymously, we had these crazy complicated ID codes for participants that were non-sequential. We only asked about child harming behaviors in the final assessment, and the participant's identity, so their name, address, email, and their ID code were linked in a single location on a super fancy USB key that was actually kept in a locked briefcase in the office, so all very spy-like. And when we would receive one of the final questionnaire packages with the information about child abuse, we would not look at it. We would immediately go to our USB key and destroy the link between the identity and the ID code. So we would essentially remove the participant ID code from the USB key. So at the end of the study, we had all of our data across 3 time points, all linked across ID codes, and we had a full list of all of our participants, and we were not able to connect the two. So the people who we had in the study were, on average, and again, this is one of the challenging aspects of this research, on average, people with a little more life stability, financial stability, education have an easier time participating in research. So our sample was on average fairly well educated. Most of the sample were married or living with a romantic partner at the time of participation. Most people, if this reassures anyone planning on having babies, the vast majority were only expecting 1 baby. About 40% were expecting their first child, and our sample, not surprisingly, given BC, was predominantly Caucasian, white, and Asian. And okay, so here are our findings, and I hope you enjoy them. I think they're pretty cool. So what Ariane, our statistician, was able to do for us was she was able to estimate the point prevalence. So the prevalence of OCD in any 2-week window for every week from 10 weeks before birth, so about 30 weeks gestation, up to about 20 weeks postpartum. We go out to 25 weeks, but you see these confidence intervals get really broad. So I would say our data is valid up to 20 weeks. So what you can see is that the prevalence of OCD increases until about 8 weeks postpartum at about 8%, and then the point prevalence drops off. So this is quite a bit more than what other people have reported. So if we go over here and we look at, and again, just to clarify the difference between point prevalence and period prevalence, point prevalence was a 2-week window. Period prevalence was the whole of pregnancy or the whole of the postpartum. So point prevalence peaked at 8 weeks postpartum. The average prenatal prevalence across pregnancy was 3.1%. Across the postpartum was 7.1%. But if you look at the period prevalence, so how many people in our sample, what proportion of our sample met criteria for OCD at any point in pregnancy, it was 6.4%. And at any point in the postpartum, it was 16.7%. And this is a crazy number. So we saw this number as we're analyzing our data. And to be honest, I had a little bit of a panic attack over this, thinking, how can this be? Everyone else finds 2%. There must be something wrong with us. So what we did, because this was so different from everyone else, we went back and we re-listened to 100% of the interviews where a person was assigned a diagnosis of OCD. So if they got a diagnosis of subclinical OCD or full criteria OCD, we re-listened to the audio recordings of all of those. Any that were not really obvious to us, we also had Fiona in the UK and Dana Thorderson, both of whom are OCD experts, listen to the audios as well to give their opinion on whether or not we had diagnosed correctly. In one or two instances, we, I think, downgraded a diagnosis from full criteria to subclinical, but those are the only changes we made. The data that you see here is based on those adjusted numbers. So this is kind of the final result. And so we feel really confident in this data. What we believe made the difference for us is really two things. First of all, there was a change from DSM-4 to DSM-5. The DSM-5 criteria for OCD is a lot looser than the DSM-4 criteria. And so there, you'll probably see the average prevalence for OCD outside of the perinatal period go up as well as a result of this. In addition, we were meticulous in asking about postpartum harm thoughts, obsessions related to the infant. Like, we really explored this carefully. We asked very specific questions about perinatal OCD, and we went to great lengths to ensure that our participants felt safe disclosing those kinds of thoughts to us, and we reassured them that we didn't need to take any action or tell anyone about it. And I think most researchers have not done that. In our experience, when you ask standard OCD diagnostic questions, people suffering from perinatal related content for their OCD typically or often don't really recognize themselves in those standard questions. So providing perinatal examples, in our opinion, is really important. So you can see that the cumulative prevalence of cumulative incidence of OCD is 10% at 6 months. What that means is that by 6 months postpartum, approximately 10% of postpartum people will develop OCD. So this is not a trivial issue. This is kind of a big deal with a pretty high prevalence of concern. Okay, so if we switch gears now to looking at this issue of parental aggression. So we had data on child abuse from 388 participants. The prevalence of aggression, physical aggression toward the infant, was 2.8%. You can see the confidence interval around that is a little bigger than I would like, which is partly why we're looking to replicate. The 2.8%, my lab is now in the process of conducting a meta-analysis of infant abuse. And our 2.8% is very consistent with what we found in our pilot research, but is also very consistent with what we see in the literature around infant abuse. So I feel pretty confident in that. And in terms of our unwanted intrusive thoughts of intentional harm, you can see this is very similar to our pilot work. 53.3% of our sample reported unwanted intrusive thoughts of hurting their baby on purpose. And just as a reminder, it is not possible that 53.3% of postpartum people in BC are abusing their children. Okay, so when we look at how do people with these aggressive obsessions or thoughts of hurting their baby on purpose, how do they differ in terms of the likelihood that they will actually behave aggressively towards their infant? So you can see that the people with the harm thoughts, 2.6% of them behaved aggressively toward their infant. The people who did not report thoughts of hurting their baby on purpose, 3.1% of them reported physical aggression toward the infant. Based on our statistical analysis of this difference is not significant. If this was a real difference with people not reporting harming thoughts as more likely to behave aggressively, we would need a sample size of 4,000 to be able to detect that difference. So that's partly why we're looking to replicate this research. I'd really like to know if there is actually any difference. Right now, the difference could be anywhere from negative 3.2 to plus 4.0. And so I think it would be really helpful for us to just kind of tighten that up. But to date, based on 2 separate studies, we have 0 data to suggest that unwanted intrusive thoughts of hurting your baby on purpose, so specifically thoughts of hurting your baby on purpose when they're unwanted and intrusive, are not associated with an increased risk of harming the infant. Okay, so when we look at OCD, this idea that has been demonstrated clinically but not tested, you can see that people with OCD were significantly less likely to engage in aggression toward their infant compared to people who did not have OCD. And this difference is significant. The outcome supports a directional hypothesis that people with OCD are less likely to behave aggressively towards their infants, which is great and really reassuring. So just to kind of finish up, and I'm checking my time to see how I'm doing. Oh, good. So I think what we can conclude from this is that OCD is more common than we previously thought. There's an increased risk of OCD in the postpartum. Perinatal specific assessments of OCD are necessary, and postpartum intrusions of infant-related harm are not related to an increased risk of violence. And unwanted intrusive thoughts of infant-related harm are reported by half of all postpartum people with no evidence of a risk of aggression, but they do look a lot like OCD. So just to finish off as my very last slide, this is content provided to me by a colleague in Italy. Her name is Alessandra Bramante, and she does research on this topic. And she has provided this beautiful graphic to help us look at the risk of harm when assessing harming ideation. And you can see that while obsessive-compulsive disorder and postpartum harm thoughts that are unwanted and intrusive are not associated with an increased risk of infant-related harm, there are some circumstances, these other 3, where harming ideation could be associated with a risk to the infant. So if a person is experiencing mood-congruent psychotic symptoms, there may be a higher risk of infant-related harming behaviors. So if someone is really suicidal, they may include their infant in that suicidal ideation, that my baby will not be safe without me. If I'm going to kill myself, I need to take my baby with me so that I can look after him or her. In the context of a postpartum psychosis, although the risk of harm is really rare, it's not non-existent. And again, in the context of a bonding disorder where the parent is struggling to connect with their infant, there's a little more risk of child abuse. And that's it. Thank you very much. Oh, here, just sorry, I didn't know if I had this last one or not. You can see here are some of the plans that we have to move things forward. I have a graduate student looking to assess maternity care providers' knowledge and intended management of postpartum harm thoughts. We're hoping to develop training materials for perinatal care providers around this topic. We have an infographic, which I will ask the folks hosting this talk to share with everyone on the call to educate people about postpartum harm thoughts, but we're also developing an animated video. It's almost done, and we will look at the ability of that video to reduce the risk of OCD development postpartum. And as I mentioned before, we're looking to replicate this work in a larger sample of birthing and non-birthing parents. Thank you very much. And I think that folks had asked me to stop at 12:45 with time for questions. So yeah, thank you.
Thank you so much, Nichole. And hope you can see all the applauses for you in the audience. If anyone has any questions, please feel free to go on video or raise your hand, and we do have one already. So feel free to unmute and ask the question whenever you'd like. Or you can also leave them in the chat if you prefer.
Hi, thank you so much for the talk. I take a really special interest in this area of medicine. I've actually done an elective during my medical training in reproductive mental health. So I really do appreciate this talk.
Well, thank you.
I was wondering, yeah, thank you. Just because you mentioned the kind of questions around OCD when you were initially interviewing patients, that they didn't align with kind of the examples that were used in the OCD questionnaire. I was wondering if you knew of any specific resources, or it sounds like your team is kind of putting together some training resources for this exact reason, to have some more specific questioning around examples so that the patients or individuals could align better with those examples. And yeah, I was just wondering if you had anything out there.
Oh, I see. So what you're asking, if I'm understanding correctly, what you're asking is, do we have some content that frames the questions in such a way that we are more likely to elicit full responses? Is that what you're saying to me? Like, how do we ask the questions differently so as to get at this?
Yeah, exactly.
Yeah, that's a really, I'm going to write that down. That's something that we could, we don't have that currently in a form that we can share, but we are, consistently in the process of developing knowledge translation products. So that would be a really great thing for us to produce as a kind of adjunct to asking diagnostic questions. So what we would find essentially is that you ask the question, are you experiencing or have you experienced any unwanted intrusive thoughts that are repetitive in nature, that happen over and over again, about violence or contamination? We give this whole list, and they'll go no. We'll say, have you been experiencing, I don't know, any recurrent unwanted intrusive thoughts about your baby, like maybe your baby being hurt or something bad happening to your baby, or maybe hurting your baby on purpose? And they go, oh my God, yes. And so that first question, even though the question about violence actually would cover off this idea of infant-related harm thoughts, they just don't connect it. And we also include a preamble about how, if they share this with us, we are not going to take any action. So we could definitely, as a team, put that content together that people could use as kind of a supplementary question when interviewing perinatal people.
Yeah, I think that's excellent. And just in my experience so far, I'm just at the end of my medical school training, and I'm hoping to do some low risk maternity care in my practice as a family physician. And so I think it would be really helpful, just because I have seen some patient specific resources out there, whether it's one modified for adolescents or a specific population. So I think that would be a really great resource if your team were to put something like that together for primary care practice.
I'm going to put my email in the chat, and if you were able to share one or two of those existing resources with me so I can see what they look like, that would be amazing.
Sure, absolutely. Thank you.
Thank you. Anne, did you have a question? Oh, no?
Yes, I hope you can hear me.
Yes, I can hear you. Thank you.
Perfect. Thanks a lot for this beautiful presentation. I have a question about period prevalence. Even though you said the numbers at the end around like 20-25 weeks, they're not very clear because the range is too high. I do have a questions about that period specifically. I'm not aware about the parental leave regulations in Canada, but I think in America there are none. And I'm from Switzerland basically, originally, and we have a parental leave of 14 weeks. And I was wondering if there might be also a higher chance of getting OCD when it comes to the end of the parental leave, when the mothers have to go back to work and to have this double burden of having a newborn at home and have to go to work. So in your next study, when you're going to extend it,
getting kind of old. I don't know if I'll be the one. But thank you.
No, I mean, if you want to do the next one with more people included, are you also going to extend the time period postpartum to check with the parental leave?
That's actually a really interesting question, and we hadn't intended on doing that, but we are currently conducting a study of perinatal anxiety screening tools. We're looking for a sample of 1,000 participants, and they are being assessed for all of the anxiety disorders, including OCD, in pregnancy and postpartum. And I think that applying for funding to conduct a follow-up questionnaire with OCD measures could be really interesting to see how the OC symptoms play out over time. So I appreciate that suggestion. Thank you. I think that could be a really great idea. And I don't know, you know, the theory around perinatal OCD is that proximity and time with one's infant is associated with intense feelings of responsibility. So one other possibility is that when parents are spending less time with their babies because they're off at work, they habituate to the threat and the thoughts actually diminish. So that would be a really interesting question to test when a person is in the presence of their infant. Is that when they're most likely to have these thoughts, or is it when they're away from their infant?
Thank you. We do have 2 questions in the chat. If you want to unmute and ask them yourself, feel free to do so, or I can ask them for you. So one question you do have is, do you have any suggestions on how to involve partners both in the information gathering phase and the family support aspect?
Yeah, I think that I would say, you know, in the information gathering phase, often in psychology, what we do is we invite the birthing person's spouse or partner to attend a therapy session and to learn about what will be helpful for their partner, but also to provide us with any information that that birthing person may have missed. And I think that's a really nice way to do this, is to include the non-birthing person in interviews and questions with the birthing person about this topic, so that they are also involved, because there's a very good likelihood that they will also experience some of these thoughts, even if to a lesser degree.
And in terms of the family support aspect?
Oh, I see what you mean. So I guess if you know, I think the place where we most often are providing the family support is around the education around how to be helpful to people suffering from OCD. The strong temptation is the person who's experiencing OCD will be very tempted to say, I'm too scared to bathe the baby. Can you do it for me? Or can you check the car seat buckles to make sure I did them correctly? Or, oh, I like to check on the baby's breathing every 15 minutes. Can you go check for me? And to really kind of pull family members into actually helping to carry out compulsions for them. So they're a participant in the workload of the compulsions and the avoidance behaviors. So the family can very easily become involved in excessive reassurance providing, or helping that person avoid things they shouldn't be avoiding. And so really educating the family about how not to feed the OCD is really important.
Yeah, you did highlight in your talk too, an appropriate response to these kind of behaviors and thoughts is actually really important to the outcome of, So that's, okay, we have a couple more questions and 5 more minutes. So Melina asks, she says, you spoke a lot about pregnancy-related stress as contributing to OCD onset or exacerbation in the perinatal period. I'm wondering whether you can speak to what is known on various explanations for the exacerbation of or onset of OCD in the perinatal period / postpartum.
Okay.
For example, let's stop.
Yeah, sorry, no, and I read that. So this is actually one of my favorite questions, and I don't have a perfect answer. There are definitely some biological models and explanations for perinatal OCD. And I have a couple of resources where we actually review some of the biological pieces. It's not really my area of strength, but what I can do is I can email either Bonnie or Romina a paper that I published and the reference to a book chapter where this content would be covered. But let me, and I presume we're kind of at the tail end anyway, let me just finish with a little story. So when my kids were small, we had this wonderful nanny work for us for about 6 months. And our nanny was of Jewish heritage. Her family had fled Europe during the Second World War. And they were only able to take with them 2 objects of value. And they were a pair of crystal champagne glasses. And our nanny was engaged to be married and was about to be married in the near future. And part of the plan for the wedding, and I'm so grateful to her for this whole story because it just is such a great example of this phenomenon. So the plan for them at their wedding is that at the end of the wedding ceremony, they were going to toast each other using these crystal champagne glasses. I'd like to ask a few people on this call, just don't put your hand up, just jump in and speak. Is there anything that goes through your mind? Is there any thought that you have when I share with you about these precious crystal champagne glasses and this couple, they're going to toast each other at the end of the wedding ceremony? Does anybody have anything that comes to mind when I share that?
Perhaps breaking the glass.
Yeah. Okay. And now did anybody else have that thought? And if you did, just like stick your hand up for a second so that we can see if anybody else also, yes. Okay. So here's what I want to tell you about that. And this is why we think postpartum OCD is more common. If those champagne glasses had been made of metal, do you think you would have been as likely to worry about breakage? Romina, do you want to answer? Just we'll have a chat so that everybody can hear the process, because I think your answer will represent most people.
Yeah, sure. No, I mean, I personally wouldn't have gone there just because it's not a material that breaks.
Yeah. Okay. And what if I had told you that they were 25-cent plastic glasses? Would you have been a bit less likely to go there?
No, I don't think I would have gone there.
Yeah. Yeah. And even if this is not maybe as impactful, but even if those champagne glasses had been like, I don't know, it was the grandparents in the corner of the room that were drinking out of them, we would also be less likely. So the features that I want to share with you are high responsibility. They are responsible for these wine glasses. So they are most likely to have the thought about what if I smash them, because they're responsible. Number 2, high vulnerability. A little baby is a lot more vulnerable than a 25-year-old bodybuilding man. And so just like the wine glasses made of crystal versus metal, a baby appears vulnerable. So you've got high responsibility for something really vulnerable. And then we add in this element of preciousness. Those wine glasses were really precious. They're really meaningful. So it wasn't just the fragility, it was the fact that they were precious, that they really mattered. So you have this combination with a newborn baby. That baby looks really vulnerable, is really precious, and you are responsible. And the idea, the belief that we have is that that combination of features increases the likelihood that we will have these unwanted intrusive thoughts of harm related to our infant. And we're having those thoughts because we feel the weight of responsibility for this precious, fragile baby. So that's an experiment waiting to happen with wine glasses to see if when we, give people responsibility, they changes the kinds of intrusions they have. So I'll let you know how that goes. So I hope that was helpful.
Yeah, that was super interesting. A very interesting analogy, and really looking forward to future research from your lab. And with that,
Thank you.
we will conclude our session today. And this video will be posted on YouTube for anyone who's interested in going back and looking at it. And Nichole has left her email in the chat as well if anyone is interested in connecting after this. So thank you again, Nichole, for joining us today.
Thank you so much for having me. Take care.
Thank you, everyone.